Workup could be something as simple as a barium swallow or barium esophagram, in which the patient will ingest barium and the radiologist will take pictures of the barium basically going down the esophagus. And that's an important study because it shows us not only some of the muscular function is intact in the esophagus, it can demonstrate reflux on the study itself, and it can demonstrate a hiatal hernia if one is present. But it's important to keep in mind that just because you don't see a hiatal hernia on a barium esophagram doesn't mean that one is not there. After a barium esophagram, the next thing that would probably need to be done would be an upper endoscopy. And an upper endoscopy can be performed by a gastroenterologist that the patient is referred to from their primary care physician, or it can be a surgeon such as myself who also does endoscopies routinely as a part of the workup for reflux. So what we're looking for in an endoscopy is abnormalities in the lining of the esophagus, abnormalities in the stomach as well. Many times we can demonstrate the hiatal hernia on the endoscopy even when it's not present on a barium esophagram. And another thing that we will find fairly frequently on the endoscopy or polyps in the upper portion of the stomach. And that occurs not uncommonly in patients who have been on proton pump inhibitors for a long period of time, such as Prilosec, Protonix, Nexium, Prevacid, Dexilant. When they take those medications over a long period of time, they have restricted the amount of acid production to the degree that the cells hypertrophy, trying to basically break out of that negative feedback loop. When that happens, we can form very small polyps that are easily seen when we do an endoscopy. These are benign polyps. It's just something that we will see frequently when patients have been on these types of medications for long periods of time. The other thing that the endoscopy is important for is again, looking at the lining of the esophagus. The esophagus can be damaged from chronic reflux. That lining is called Barrett's esophagus. Another whole spectrum of workup we didn't talk about. One of this is called the 24-hour pH and the esophageal manometry procedure. The 24-hour pH is an important study when we cannot prove on any of our other previous studies that you have reflux. Now, esophageal manometry is an important adjunct to the workup of a patient that has reflux because it can tell us if they have something other than reflux, such as motility disorders like achalasia. So we treat achalasia, but achalasia is not treated the same way as GERD. But that is one of the tests that can help you sort that out. The overwhelming majority of patients that have symptomatic reflux, we can prove it.